morning everyone and welcome to this class on topical fluorides. As you know that the fluoride delivery methods are classified into topical fluorides and systemic fluorides, and today we are going to discuss on topical fluorides. Now topical fluorides are placed directly on the tooth surface, and by definition they are those delivery systems which provide fluoride for a local chemical reaction to the exposed surfaces of the erupted dentition. So these preparations are like either we can use it as on a high concentration for a short period of time or as a low concentration for a continuous usage. Now what are the main indications? It is indicated in caries active individuals, the children shortly after periods of eruption, or when the caries risk is high like rampant caries, nursing bottle caries, root surface caries, or xerostomic patients where the salivary flow is very less and the caries risk is very high. Even after periodontal surgery when the roots are exposed, or the patients with fixed or removable prosthesis, the patients with eating disorders, and even the mentally and physically challenged individuals, and there also the indications are there. Topical fluorides are broadly classified into professionally applied topical fluorides, that is by professional dentists or qualified people, or even you can apply self, that is the self-applied topical fluorides. Now we'll see first professionally applied topical fluorides. The professionally applied topical fluorides are of sodium fluoride, stannous fluoride, acidylated phosphate fluoride or APF. Then we also have fluoride varnish, fluoride impregnated flows and prophylactic paste, or fluoride containing dental materials and devices. The self-applied topical fluorides include fluoridated dentifrice, mouth rinses, and even gels. So first, professionally applied topical fluorides. The professionally applied topical fluorides, as I said, it is mainly the high concentrated fluoride which is applied on a short period of time. So it is started with Eby in the year 1942 when he found out that the repeated application of sodium and potassium fluoride reduced caries. So in professionally applied topical fluorides, we usually use the fluoride vehicles as aqueous solutions and gels, or even the foam type, sometimes as prophylactic paste, or even as fluoride varnish also. So in that, we'll first see fluoride varnishes, because it is actually very important. And in fluoride varnishes, what happens is that the fluoride is incorporated in varnish-like coating materials and then apply it. So the main fluoride varnishes which we use are three, and it is started in Europe, and the first one is Durafat. Durafat is found out in Germany, where they use 22,600 ppm of sodium fluoride in a neutral colophonium base. So the percentage is 2.26%. The next one is Fluor Protector. Fluor Protector is 0.7% of fluoride. So it is a clear polyurethane based product which contains around 7,000 ppm fluoride from an organic compound difluorosilane. So it is also actually easy to remember, 7,000 ppm and 0.7%, whereas 26,600 ppm is 2.26%. And the Durafat is having around 30 to 40% of caries reduction, which has been shown. And another product, Carex, which is of less fluoride concentration, only 1.8% of fluoride, but the efficacy is almost as that of Durafat when it comes to the caries prevention aspect. Now, the technique of fluoride varnish application is that first you do oral prophylaxis and make sure that the teeth are dried. There is no need of isolation with cotton rolls, as it is very easily that the fluoride varnish will stick to the cotton rolls. So there is no need of isolation with cotton rolls. You can use around 0.3 to 0.5 ml varnish, which is required for the whole dentition. And the application is first on the lower arch, followed by the upper arch. As you know that salivary contamination is more in the lower arch, or first in the lower arch. And after application, the patient is made to sit with the mouth open for 4 minutes. And patient is asked not to eat, rinse, or drink anything for 1 hour, and also even to avoid the hard solid food for around 18 hours. So this is how the technique of fluoride varnish application. Next, we will move on to the different professionally applied topical fluoride compounds, and the first one in that is sodium fluoride. Now, sodium fluoride is mainly a 2% of solution, and this is prepared by dissolving 0.2 grams of sodium fluoride powder in 10 ml of distilled water. And the solution is stable only if it is stored in plastic containers. Because in a glass container, what happens is that the fluoride ion reacts with silica and forms silicon fluoride. So that is why it is stored only in plastic containers. And the technique of application of sodium fluoride is known as Knudsen's technique. Very important question, Knudsen's technique. So in Knudsen's technique, what is there? After the oral prophylaxis and the teeth are dried, it will be thoroughly wetted with the 2% sodium fluoride solution, and it is allowed to dry for around 3 to 4 minutes. And the number of applications will matter. There are total of 4 applications in one age group. That means within 1 week interval, you have to have 4 applications. First week, first application. Then after a week, another application. Like that, there are 3 further applications, a total of 4 applications in 4 recommended age groups. And the age groups are 3 years, 7 years, 11 years, and 13 years. So a total of 16 applications will come, like 4 age groups. In each age group, 4 applications. Now let's see the mechanism of action. The principal compound which is formed after the application is the calcium fluoride. And once a thick layer of calcium fluoride is formed, it interferes with the further uptake of fluoride ions. And from there won't be any further intake. So that results in a phenomenon which is known as choking off effect. Choking off effect, which is due to the calcium fluoride. So that is why sodium fluoride, once applied, is left to dry for around 4 minutes. Then the mechanism of action is almost similar, like this calcium fluoride will react with the hydroxyapatite in the tooth, and which forms the fluorapatite, which is the most strongest one, which will avoid or prevent the dental caries. Now the advantages of sodium fluoride is that it is acceptable taste. And as I said earlier, it is stable only if it is stored in plastic container and refrigerated. But it is non-irritating, there is no discoloration. And another advantage is that it is a multiple chair procedure, so that the patient will also come in multiple times. But again, it can be called as a disadvantage also, because the procedure requires around 4 visits to the dentist in a relatively short period of time. Like within a 1 week interval, only the patient has to come 4 times. And again, he has to remember it 4 age groups also. One weight is an advantage and another weight is a disadvantage also. So that is about 2% sodium fluoride solution, and the technique name is Knudsen's technique. Okay. The next we will move into stannous fluoride, the next compound. Now stannous fluoride is usually given in 8% or 10% solution, and we mainly use as 8%. Here the solution is not stable. Soon after mixing, it will become cloudy and there will be formation of tin hydroxide. And how the solution is formed is that you dissolve 0.8 grams of stannous fluoride powder in 10 ml of distilled water. And here the technique name is called Muhle's technique. In sodium fluoride, so it is Knudsen's technique. In stannous fluoride, it is Muhle's technique. Again, the procedure is almost same. Do the prophylaxis and use the dental floss and everything. After that, you isolate and dry with air. Keep moist with the solution for around 4 minutes. And here the repeat application is every 6 months. Whereas in Knudsen's technique, it is 4 applications in 4 age groups, a total of 16 applications. Here it is a biannual application, that is every 6 months it is applied. And the mechanism of action, that it is under the low concentration, tin hydroxyphosphate is formed, and this tin hydroxyphosphate is the one which gives the metallic taste to the solution, which is one of the disadvantages, a metallic taste which is there. And that is because of the formation of this tin hydroxyphosphate at the low concentration. Whereas in high concentrations, you will get calcium trifluorostannate and even tin trifluorophosphate. And this tin trifluorophosphate is the one which makes the tooth more stable, and because of that, the caries prevention will be more. That is, it will be less susceptible to decay. And that the end product will get again the calcium fluoride, and as usual, like in the previous solution, this calcium fluoride will react with the hydroxyapatite in the tooth and will form fluorapatite crystals. Advantage is that it conforms to the usual patient recall system, because it is a biannual application, and we always tell that the patient to come and do the checkup once in 6 months. So it is like a 6-month application. So it is like a normal patient recall system. And disadvantage is that there are a lot of disadvantages for stannous fluoride. That is why we are not using stannous fluoride, very common, because it has got a bitter metallic taste. It has to be freshly prepared in each application. It is not very stable in solution, and it may cause reversible tissue irritations and even staining at the margins of the restorations. So because of all these disadvantages of metallic paste or tissue irritations or margins of restoration, staining and everything, we use stannous fluoride very less, even though it has got a good caries prevention capacity. Now moving on to the third fluoride compound, which is APF gel, acidylated phosphate fluoride gel. Now this is invented by Brudewald and co-workers at Boston in the year 1960s. And how the solution is made is that you dissolve around 20 milligrams of sodium fluoride in 1 liter of 0.1 m phosphoric acid. And to this you add 50% hydrofluoric acid to adjust the pH to 3 and the fluoride concentration at around 1.23%. So this solution is known as the Brudewald solution. The percentage of the Brudewald solution is 1.23%. And if you want to prepare a gel, then as usual, you have to add a gelling agent. So we usually add methyl cellulose or even hydroxyethyl cellulose. So once you add the gelling agent, it will become a gel and the pH is adjusted to around 4 to 5, whereas the solution has a pH of 3. Okay. Now coming to the mechanism of action of APF gel is that as soon as you apply, there is an initial dehydration and shrinkage in the volume of the hydroxyapatite crystals. And then it will form an intermediary compound, which is very important. That compound is known as DCPD, dicalcium phosphate dihydrate. So there is an intermediary compound formation, dicalcium phosphate dihydrate. This dicalcium phosphate dihydrate is very highly reactive with the fluoride and leads to the formation of the fluorapatite crystals. And the main advantage of this intermediary compound is that it is having a deeper penetration. So this fluoride penetrates into the crystals more deeply through this opening of the shrinkage. As I told that initially there will be a dehydration and shrinkage, and through this the fluoride penetrates into the crystals more deeply. And so for that, a continuous supply, this APF is applied every 30 seconds during the visit. Now the advantages are that it is a stable compound and it can be even self-applied also sometimes, and ability to deposit fluoride to a deeper depth. That is the main advantage. And there are certain disadvantages also. It has got a slightly acidic, even sour or a bitter taste, you can say. And again, you have to do some frequent application because as I told, every 30 seconds you have to apply for in that visit. And sometimes it adjusts the composite and porcelain restorations also. So that is again a disadvantage. But the main advantage is that of the deeper penetration, and because of that we commonly use APF gel in our clinics and hospital settings. Now there is also one more which I wanted to mention is that amine fluoride. In amine fluoride, it is found out by Muhellmann and co-workers in the University of Zurich in the year 1957, and this is a karyostatic agent, but it holds fluoride for a longer time. That's the advantage, and again got antibacterial properties and all. But mainly we concentrate on 3 main topical fluoride compounds, which I have compared it in a table which you can see. Sodium fluoride, stannous fluoride and APF. So the percentage is 1 is 2%, even though stannous fluoride is 8 and 10%, we commonly use as 8%, whereas APF is 1.23%. The ppm is for sodium fluoride, it is 9,200 ppm, stannous fluoride 19,500, APF is 12,300. The frequency of application where it matters for stannous and APF, it is only a biannual application, but for sodium fluoride it has to be in 4 age groups of 3, 7, 11 and 13, and you have to have 4 weekly applications in each age group. So the stability is sodium fluoride is a stable compound, stannous fluoride is very unstable, and APF is stable in plastic container. pH is neutral for sodium fluoride. For stannous fluoride it is 2.4 to 2.8, and APF it is 3. If it is a gel, then it comes to 4 to 5. Main adverse effect are for stannous fluoride because of the tooth pigmentation, gingival irritation and everything. But you can see the caries reduction is maximum in stannous fluoride, is 32%. But because of all these disadvantages, we don't use stannous fluoride that much, but we use APF gel. Even though the caries reduction is less, it is having more deeper penetration and of the usage and everything. So this is the comparison of the topical fluoride agent, professionally applied topical fluoride compounds. Next is the self-applied topical fluorides. You have professionally applied and self-applied. Under the self-applied is the one which is can use it as self. You can give it to the patient and the patient can use it. Only thing is that you give only low concentration for a continuous usage. Mainly that is because to avoid the toxicity and everything. So in that self-applied topical fluorides, you have fluoride dentifrices, fluoride gels, and fluoride mouth rinses. First, you will see the fluoride dentifrices. The term dentifrice derived from the Latin word dens, which means tooth. Fricere means to rub and everything. So it started in 1955, where the first dentifrices is recognized by the Food and Drug Administration (FDA) is the stannous fluoride dentifrices, and it is again mainly the work of BP and everything. So the first fluoride dentifrices was accepted by the American Dental Association in the year 1964, and mainly we use sodium fluoride dentifrices, stannous fluoride dentifrices, monofluorophosphate dentifrices, and amine fluoride dentifrices. But the most commonly and widely used one is the monofluorophosphate dentifrices. Remember that it is a very frequently asked viva question, or even as an entrance question also. The fluoride compound which is most commonly seen in dentifrice is monofluorophosphate compound. And the Food and Drug Administration also recommends the fluoride content of the dentifrice containers should be limited to 260 milligram of fluoride. That is mainly to avoid the fluoride toxicity. Accidental fluoride ingestion and all can cause acute fluoride toxicity and everything. So in order to avoid that, the maximum limit is limited to the 260 milligram of fluoride. And how do you use it, or the recommendation of fluoride dentifrice use is that below 4 years, fluoride toothpaste is not recommended at all. 4 to 6 years, you can brush with fluoride only once and twice without the fluoride paste. Whereas 6 to 10 years, you brush twice with fluoride and once without fluoride paste. And above 10 years, it's like brush twice daily with fluoride paste. So it's not recommended below 4 years, and from 4 years to 10 years on an increased usage. Initially at only once, and after that can be brushed twice daily. Next is fluoride mouth rinses. Fluoride mouth rinses are founded by Eby et al. In the year 1946, and we mainly use sodium fluoride as the fluoride mouth rinses, and we have the concentrations in daily usage and also even in weekly usage. So for daily usage, we use around 0.05%, that comes to around 225 ppm. And for a weekly usage, we take around 0.2%, which gives around 900 ppm, because it is a weekly usage, so you need to have more ppm. Whereas in a daily usage, you give only a very mild dosage of around 0.05%. And the recommended mode of usage is that you take the fluoride mouth rinses of around 10 ml and you swish it in the mouth for around 1 minute. For around 60 seconds, you swish it and then spit it off. That's how you use the fluoride mouth rinse. And the main indications are for the caries-prone children of over the age of 6 years, and all those patients who are having erosions, root caries, even dentinal cemental hypersensitivity, and even the patients who wear orthodontic appliances, because for them self-cleansing will be a little bit difficult. So in that case, use fluoride mouth rinse. And the contraindication is that it should not be used below the age of 6 years. And the third is fluoride gels. Fluoride gels, we mainly use sodium fluoride or even APF also, acidylated phosphate fluoride. So sodium fluoride and APF, it is around 5000 ppm, in that range we use, whereas stannous fluoride we use around for 1000 ppm. So fluoride gels we can use by brushing the teeth for 1 minute with gel, or if it is sometimes we use customized trays and in that fluoride gels, and you tell the patient to keep it. So in that time, you held it for around 5 minutes. But if you're brushing the teeth, you brush the teeth with around 1 minute. So for 5 minutes for holding the tray. And but the usage of fluoride gels is not that recommended because of the toxicity hazard. Because there are always chances that whenever you keep the tray and everything, there can be an accidental ingestion and everything. So it is very tedious to use. So that is why, because of toxicity hazard and everything, we reduce the usage of fluoride gels until and unless it is needed. So to summarize, we have taken the topical fluorides broadly divided into, you have professionally applied topical fluorides and self-applied topical fluorides. In professionally applied topical fluorides, we saw fluoride varnishes, mainly Durafat, Pro Protector, and Carex. And the main professionally applied topical fluoride compounds are sodium fluoride, 2% sodium fluoride, 8% stannous fluoride, and then 1.23% acetylated phosphate fluoride. In sodium fluoride, the mechanism of application is Knudsen's technique. You also saw the choking off effect. In Knudsen's technique, the application age groups are 3, 7, 11, and 30, and it is 4 applications in 1 week in 4 age groups, total of 16 applications, whereas stannous and APF both are biannual applications. In stannous, it is Mueller's technique, and in Brudivol's, it is Brudivol technique, wherein we have the intermediary compound which is formed, which gives its deeper penetration, that is dicalcium phosphate dihydrate. And when it comes to self-applied topical fluorides, you have fluoride dentrifiers, mouth rinses, and jets. Okay, that's it for today. We have completed the topic, topical fluorides. We'll continue in the next class. Thank you.